Good morning. As I put these slides up, I just want to acknowledge Sarah Peno, whose slides I partly pinched and somewhat modified. She had just some nice, simple slides. So, just kind of thinking about what cancer is and what a patient might go through in terms of a cancer diagnosis. So if we imagine cancer as the skin, something that we can see, and many patients who have cancer that are deep inside, who don't have a knowledge of what that looks like, don't get so upset about it. But when you see something, it's a bit more freaky. In terms of thinking about the skin and thinking about a cross-section through the skin, we've got our normal cells covering the surface. And then when a cancer forms, you get a few abnormal cells that become a bit more abnormal with time as changes happen within the genes and the DNA of the cells. You get an abnormal growth, and then it moves towards more of an uncontrolled growth. And by uncontrolled, it just keeps heaping up. So if you think about a cut that you might have, and in 2 months' time, you can actually not even see where the cut was. What has happened there is you've cut billions of cells, but over 2 months, it's all healed up, sealed over. How has it done that? It's done it by asking cells to cooperate and divide, and then something else has told them actually to stop. Hey, that's enough. Some people have got overactive scarring, and they produce a very heaped up scar. So that's slightly abnormal, so-called keloid scar, and maybe seen people with very prominent scars. But that's not a cancer. But if you think in those terms, a cancer is something that doesn't stop, it just keeps piling up, doesn't behave the control signals. It's like a car gone loose in Palmerston North that isn't going to obey the traffic lights. It starts to cause a bit of chaos and mayhem. Lymph drainage channels and little blood vessel capillaries draining the skin are conduits or canals whereby cells from the cancer can actually drift off, speed through the system and find themselves in a distant place in the body. And if one cell can then divide into 2, into 4, into 8, 16 and so on, very quickly you've got millions of cells, and it actually takes billions of cells before you can actually see it with the eye. Scary. We think our scans are marvelous, but actually in terms of detecting cancer, our scans are hopeless, because they only detect billions of cells. They can't detect one blighter that can divide into 2, which would be perfect detection. So cancer can be a bit sneaky in that cells get present in the system and you don't actually know they're there. If we look a bit more under the microscope at what's happening around those little tumours that are growing, the small one to your left has got to a size where it doesn't require its own blood supply. It's getting nourishment from the fluids around it. But it's also producing little signals between the cells to say, hey boys, let's grow, let's divide, let's get a bit bigger. And as time goes on, some of those signals actually say, hey, we could do a bit of a blood supply, so it actually encourages blood vessels to grow in and then actually nourish it so it can actually get to a bigger size. And some tumours can get to sort of 20, 30 centimetres in size, which is really quite a big chunk. Although most tumours are quite a bit smaller than that. Why does cancer start? And most cancer thinking is indeed around the genes, and it is a bit as to who your parents were. That sets up what your DNA is going to be like. However, very, very important thing is our age. And possibly some of us in this room have noticed that certain things don't go quite so well with time, like our joints, like our hearing, and maybe our eyesight, and other parts tend to wear down a bit with time. And it's the same if you look down at the microscopic level on the cell is getting a bit worn down as well. And some of that is around repairing itself. And all the time our cells are getting bits of damage here and there, and the clever mechanisms within the cell actually repair those bits of damage. But with time, our repair mechanisms get a bit slack and not so good, and then bang, you can get a finding that isn't cleared up, isn't healed, and it's a change in the cell that starts to produce a malignant process. Add to that some environmental factors like sun damage in terms of skin cancer, asbestos in terms of being a real carcinogen within the lung in particular, radon gas that we don't really think about, but that actually comes from granite, from within the rocks of the earth. Infection, human papillomavirus in terms of cervical cancer and some head and neck cancers, throat cancer from that virus. Most of the times we clear the virus. Most of the time we can have the virus and not get cancer, but a number of people get that hit on their DNA that produces a cancer. And the same goes for hepatitis B, that is quite common in Asia. I think it's relatively common in the Pacific Islands. And hepatitis B can, with time, cause chronic inflammation in the liver and go on to eventually the repair mechanisms can't keep up and a cancer can form. And the other interesting thing is that for a cancer to be formed, it takes many years before the cancer actually appears. So that's maybe why smoking, I've smoked for 40 years and it hasn't touched me. Hello, but another 10 years and it might well have touched me with a nasty lung cancer, because it takes time for those hits to occur, for the DNA repair mechanisms to give up, and bang, the cancer appears, often decades after the first stimulus that was caused, in this case cigarette smoking, to eventually cause the cancer. Issues in our diet, lack of exercise, having excess weight, alcohol are definitely influences for some cancers. It's the other thing. There is no one cancer. There's about 250 different types of cancer, and they all need to be considered a bit differently. So how is cancer found? That's early detection, usually from the fact that someone's complained of a problem, a symptom, that has then led to a test that has turned something up, that then goes on to get a biopsy, so a bit of it's taken to find out what it is, and then bang, you're into the whole cancer arena, which we'll come to towards the end. So can we screen for cancers? That is, can we look at the normal or healthy population and try and detect very early cancers? Because if we can detect cancers early, that might be a good thing. In general, it is a very good thing to detect a cancer early. And there are some cancers whereby screening the population is a good thing to do. So it's really testing people who don't have or haven't recognized any signs or symptoms of the condition that is being looked for. So breast cancer is one, cervical cancer another, and bowel cancer is one that's going to be a common thing that's been screened for in the years to come. Prostate is a difficult sort of issue. I don't want to go into discussing that today unless some people want to grab me over tea or something. And screening is a program, it's not a test. It's not about picking up, well, it's just about picking up diseased people, but it's actually going through what seems to be a normal and healthy population. I'm not going to elaborate on this slide because it's a bit difficult to get your head around, but for every 2,000 women screened for breast cancer over a 10-year period, one will have a life prolonged by that screening. Doesn't sound like a lot, does it? But this is about picking up and curing, and you need to go through a lot of normal people to pick up the ones that are abnormal. If you look at prostate, again, 1,410 men needed to be screened, and you'll pick up 48 with prostate cancer, but you treat them, you only get one improvement out of all of that in terms of survival benefit, because the others would have been picked up in a way with time. It wasn't just the screening test that led to the benefit. So the complicated arguments about screening a normal population, and got to be careful about how many good things you get out of it, that is lives saved, compared with the bad things that you can get out of it by picking up people who seem to have something abnormal, but it turns out not to be. They get a few tests done and they might get complications from that, and they might get treatment and get complications from that. And actually, it may not have been the best thing to have screened them. And that's a very controversial area when it comes to prostate cancer, as to whether you should or shouldn't go and check that up early or not. Very, very, very complicated area. So what surgical treatment for cancer? That's to cut it out effectively, which could be minor, say taking out a small skin cancer, or it could be major, which might be as drastic as an amputation. And that can affect the body image quite dramatically and can lead to long-term problems. Although much surgery seems to be fine with just a scar on the belly or the chest. Radiation therapy is using strong X-rays, which come from the universe out there all the time, from the sun, but they are harnessed in different ways, mainly by powerful electrical machines that generate X-rays that can fire into cancers, and with clever use of machines you can fire them into where you want that treatment to be given at a big dose to try and kill the cancer off, or to try and treat any cells. Remember, those cells from cancer are extremely tiny, can't see them, but maybe following surgery you want to treat an area with radiation to mop up any cells that might remain within the field. And you might use radiation treatment simply, not necessarily to cure the cancer, but to help someone who's maybe got a cough that the radiation can fix, or pain that the radiation can fix, even though it may not eradicate the cancer completely. Here's a radiotherapy machine, lie on a table, big thing above you, it can whisk around and fire the treatment into the appropriate area of the body with fancy computers to fire it in the right place. Very expensive as well. Chemotherapy, this is one of the areas where there's a lot happening. And when I was a younger sort of fellow in oncology, patients would say, oh, it's all right, you'll find something in the next 5 years that will fix me anyway, so it doesn't matter if you can't cure me now, you'll find something new. Back then I was thinking, oh no, we won't, because it took at least 10 years for a new development. But today, actually, new developments are coming on stream all the time. Remembering again that there's 250 different types of cancer, it's not necessarily for the common ones, it might be for some of the rarer ones, but new treatments are coming through big time as knowledge increases and better ways of getting drugs to target the whole thing about how cancers grow and how to stop them growing. And we're moving away from the concept of eradicating cancer for good, more into viewing cancer as a possible chronic condition that, although we may not eradicate and cure it, at least you can keep it under control for long periods of time. And definitely that is happening today. Obviously, to cure is better. Now, drugs can also be used when there is no visible sign of the cancer. So again, going back to that idea that cells are very small, can be spread in your body, chemotherapy can be given to mop up those cells that you feel there's a high chance that they might be in the system. The less number of cancer cells that are present, the more effective chemotherapy and radiation is. So if you can't see them, they're going to be even more effective. Remember what I said? To see them, you've got to have how many? many millions basically, before we can actually see the tiniest cancer, often billions. So that's why you're kind of treating in the dark sometimes, just knowing there's a high risk. Why is that the case, that if there's less cells, the more effective treatment is? It's because the more cells there are, the more chance the cancer has got of having a resistance factor within it to the drugs that we use, much like antibiotics. The more antibiotics you use, the more bugs there are, the more chance there will be of resistance. Quite a bit the same with chemotherapy. Let's not worry about how the drugs work. So, what's happening in terms of cancer in New Zealand at the moment? So, I'm doing fancy statistical gizmos on this and making comparisons with worldwide figures. Basically, the top line in green shows that the registration rate for cancer is not going up and up and up and up and up, like some people think. And the death rate for cancer is coming itsy-bitsy down, which is a good thing. There is going to be more cancer within New Zealand because more of us, who are part of the baby boomers, are getting to that age that we're going to start developing cancers. And there are many more of us coming through than there have been in the history of New Zealand. So it's more to do with an aging population than with the fact that cancer is getting more and more common. Some cancers are actually getting less, and very few are getting slightly more common. So lung cancer in blokes is coming crashing down because blokes generally have got the message that smoking is a bad thing. In women, it's gone up like a NASA spaceship because women have sort of cottoned on to equality with cigarettes, and not good. So the people you see downtown smoking, often young females, not good. So we need to reverse that trend because there'll be a great rise in lung cancer in women in years to come. Can you see this? I can't. So this is a patient who's in Hawke's Bay, presents to their GP of something. Oh, I've got a pointer. So patient here at the outset goes along with an issue. I think it's, let's say it's a cough. GP orders a chest x-ray, so they shoot out to somewhere else, get the x-ray, come back and see the GP possibly a week, possibly 2 weeks. Sometimes they forget about it and it's too long afterwards, come back. GP says, ooh, not too happy about this x-ray, need to send you to a specialist. GP may or may not mention their concerns about a possible cancer. They go along to outpatients and see a specialist, who then will probably order more tests and organise a biopsy if they're concerned. Come back to see the specialist, who maybe has got a better pointer than mine. Yep. Is it your head? Target on your bald head. She shaved her head for charity, isn't that nice? I just grew like this. And the biopsy comes along. Bad news. We've got a tumour sent off to the big bad hospital for some activity. That's down at Cape Coast Health. So it's been sent from Hawke's Bay down to Wellington to get thoracic intervention, because that's where the thoracic surgeons are. Deal with the chest issues. Come back after a successful operation. But is it successful? Because they've been now referred to radiation oncology and chemotherapy and saying, well, what's all that about? So it's a high-risk cancer that has the chance that cells are spread in the system, and they're recommending that chemotherapy and radiation therapy be given as well. So we're getting the whole package. But when they get back to Hawke's Bay, they're actually seeing a radiation oncologist and a medical oncologist who visit from Palmerston North, because that's where the team visit from up into this area. They organise the treatment. Radiation treatment is done in Palmerston North, and chemotherapy is done in Hastings. So it's quite complicated, isn't it? But some of our patients can undergo quite a complex journey to get through the whole lot. One of the aims of the Cancer Network is to try and make that journey as smooth as possible. But just to help your understanding as to how complex that can become, and you've got the whole fear factor, you've got the whole support squad that might be required to help the person navigate through all of that, or some psychological support, or financial support, all sorts involved there. And just to finish on a few myths around cancer, you don't catch cancer. Cancer is, as I said, about 250 different types. Cancer is definitely not the patient's fault. So some people will blame themselves. If they've been a cigarette smoker and they've got lung cancer, they might well blame themselves. Not all lung cancer is due to cigarette smoking. Most of it is. But again, it's not about blame. Most people survive the cancer. And for major cancers in New Zealand, about 65% will be alive 5 years after their cancer, major cancers. Okay? So it's not a death sentence. It is for some. We want to improve the death rates, but actually it's not as bad as people think in their minds. Cancer is not mainly due to toxins. So I think, it's all to do with the stuff we breathe in and the additives to our food. Rubbish. Absolute rubbish. People are still smoking with gay abandon. If you do one thing, get rid of tobacco, you'll have done the whole world a major good service, and 30% of cancer will go within 10 years. Just with tobacco. It's the biggest single hit that we can have. Cancer is not increasing in terms of the rate of cancers getting more and more and more and more because of the toxins in our air and the bad food that we eat. No, that is not what is happening. And the fact is we have cures for several cancers. We need to do better, but many cancers are curable. Much cancer is preventable, and that's a big story we need to work very hard on. And most cancers are actually very treatable as well, even though they might not be curable. End of my spiel.
Thank you, Simon. And as I said, that we'll keep some questions to the end. I'm just conscious that this first session is going to be actually quite tight for us to get through, but we are going to have some time for discussions and things as we go through the day.